Good evening, everyone. It's a pleasure to be with you. My name is Dr. Michael Gonevski. I have been dealing with decompression for the last 10 years as a hyperbaric and diving physician at the Midlands Diving Chamber in Rugby. With some of you, we might have met. With others, we still might have an encounter. And I hope it's only going to be for a routine medical examination rather than anything else. When we talk about decompression illness, I would like to approach the subject from a slightly different perspective. I do not want to go too much into theory, more than absolutely necessary, but to concentrate rather on clinical cases of decompression illness from my experience. The next time you go diving, it may be you or your dive buddy who's feeling strange after diving, so it will be very helpful for you to be able to recognize the symptoms when they appear. So the term for decompression illness, the one that we use, is the bends. It is a disease that no matter whether you're an experienced or novice diver, nobody is immune to. Many of you are probably familiar with the term the bends, which dates back to the late 19th century and the construction of the Brooklyn Bridge. And it was named after a particularly fashionable style of walking of the ladies at the time. But ignoring that, you can imagine the severity of the pain the workers that worked on the bridge were suffering from if they had to walk like that. So, where do bubbles come from? That is the question. That these bubbles cause the problems that eventually become the decompression illness symptoms. Probably the most important gas law that has implications on diving is Henry's law. As the pressure and depth increase, the amount of absorbed gas by the tissues increases exponentially as well. Most frequently, the mixture that we breathe contains is air, which is oxygen and nitrogen. So we utilize all the oxygen, but the nitrogen is the inert gas that accumulates in the tissues. So the deeper and longer we stay underwater, the more gas gets absorbed. So the pulmonary filter in the lungs is where the absorbed gas eventually has to diffuse with the blood into the blood and be exhaled as a gas. However, if there are any provocative conditions, for example, a rapid ascent to the surface, this absorbed gas will come out as bubbles. And here is an example of bubbles in the brain. You can see them where the arrow is pointing. There are, of course, other mechanisms of development of bubbles. For example, provocative conditions like pneumothorax or pulmonary shunt can cause the bubbles to cross over and spread out and cause problems as well. Now, I want to emphasize the factors that promote bubble formation, which are very diving related. So rapid ascents to the surface, multiple ascents, missed safety stops, and altitude exposure, which is usually a long-haul flight from a diving destination back to our home. Factors including nitrogen uptake, strenuous exercise, repetitive dives, and higher body fat percentage. Which systems and symptoms are the most frequent ones? The short answer is that any system can be affected, but the most common one by far is the neurological system. You can see a list of the more common system symptoms on the screen in declining order. So every case of decompression has to a certain extent neurological symptoms. And that will become very clear from the clinical cases that we're going to move to straight after this slide. So the first case is demonstrates how seemingly small mistakes lead to serious problems. This was a dive in a local quarry in the middle of England during a weekend, which is a very typical scenario for most of us. There were 3 dives on the first day and 2 dives on the second day. The first dive on the first day was to a depth of 26.9 meters that lasted 18 minutes. This was followed 16 minutes later by another dive to a depth of 12.8 meters, which lasted 18 minutes. The third dive on that day was 1 hour and 28 minutes later, and it lasted 25 minutes. There were no immediate symptoms after the first day of diving. So far, so good. On the second dive, however, the first dive was to a depth of 20.6 meters and lasted 32 minutes. 1 hour and 11 minutes later, there was another dive to a depth of 7.8 meters that lasted 14 minutes. There was a long surface swim to get to the second dive of about 150 meters, which obviously was followed by another swim at the end of the dive when it finished. And the symptoms started even during the swim back to shore. So the diver was out of breath, confused, disoriented, and he had to be helped out of the water. There was lightheadedness, nausea, pain in both arms and elbows, mostly on the left side. The staff at the dive site recognized that these symptoms are diving related, and this could be very well a case of decompression illness, and put the diver on 100% oxygen. He was later transported by ambulance to the Midlands diving chamber for evaluation and treatment. On examination, his balance tests were all positive, so he couldn't stand on his feet. He was severely dizzy. There was localized pain in both arms and elbows, and he had difficulty even breathing. So what is wrong with this picture? First of all, the diving profiles of the diver didn't show anything unusual or problematic. The dives themselves were conducted very well. However, there was a very short surface interval on the first day of only 16 minutes between the first two dives, which was insufficient to off-gas safely the nitrogen that was accumulated. And there was a long surface swim before the last dive, which was also problematic because physical exertion before and after diving is a very significant risk factor for the development of decompression illness. This diver had a high BMI, body mass index. Physical fitness also is a factor, and of course, all of these dives were conducted in a cold water environment. So all of these factors led to the development of symptoms of decompression illness. The diver was successfully treated in the chamber and had an overall improvement of 95%. We managed to get him in the chamber within 2 hours of surfacing. So that was a very good outcome for this diver. He needed, of course, a few retreats before complete resolution. The second case that I want to discuss is I call it the Red Sea liverboard, because this diver went on a liverboard in the Red Sea for 6 days, which is a scenario that you're only too familiar with. He contacted the chamber due to symptoms that he developed after diving for 5 consecutive days. During this period, he did 16 dives, and he was diving on average 3 times a day on most days. The dives were in the 11 to 23 meter range, and the bottom time was between 40 and 70 minutes. He took extra precaution and did all dives using nitrox and following air tables, which is a very sensible thing to do, apart from the very first one, which was on air. There were quite a few dives when we looked at the profiles after that had the seesaw profile, 7 of them actually. On the 4th day of diving, after he surfaced of the last dive of the day, he lost his camera and returned immediately to depth to retrieve it. Practically, he had another dive without any surface interval. There were no immediate symptoms that he was aware after the last dive finished, and he flew back to the UK more than 24 hours after the last dive finished. So everything according to the accepted guidance. His symptoms, however, started on board of the plane, with intermittent headache, which was quite significant, 7 out of 10, but fully developed only after landing. He started to complain of intermittent pain in the right shoulder, both hands, and lower back. Since this diver was treated previously for decompression illness, he was aware that any symptoms after diving would be diving related, and this prompted him to call the diver emergency number to ask for advice and evaluation. On examination, he was feeling tired more than usual. apart from all the symptoms that he already had a little shortness of breath, itchiness to the front of the chest, and severe headache. So what is wrong again with this picture? Deep and long dives over a brief period of time. That was the main problem. He had 7 dives with provocative seesaw profiles up and down. Probably this is not unusual if you dive on a coral reef and you follow the contour. He also had 1 dive when he returned immediately to depth after surfacing, practically having another dive with no surface interval. The constant release and uptake of inert gas inevitably led to the development of symptoms of decompression illness. It is typical for people on a liveaboard who have usually unlimited access to diving over a few days to load with nitrogen gas and be unpredictable, which becomes unpredictable by the accepted computer models. So my advice for people on a liveaboard will be to be extra careful and have a 24-hour break every 3 days. This practically means that you should stop diving in the morning of the previous day and resume diving in the afternoon of the following day. So in this way, you have 24 hours break. Just want to emphasize another important point. The flight back home was more than 24 hours after he finished diving, and yet he managed to develop symptoms on board of the plane. So the advice to delay flying for at least 24 hours is very sound, but it is just an advice. And if you can have this longer, if you can make this period longer, that is even better. Very typical for decompression illness is the fact that the diver reported intermittent symptoms. They were coming and going. So at one point, he might be lucid completely, feeling no symptoms whatsoever. And at another point, the symptoms can come back like a wave over. This is usually followed by another lucid period. So this is very typical for symptoms of decompression illness, the fact that they come and go. The next slide is case number 3, the diver with the PFO. I want to address here one specific cause for the appearance of seemingly unexplained decompression illness with predominantly neurological presentation. Foramen ovale is an opening between the right and the left atrium in the heart. This is a normal leftover from the embryologic development. Normally it closes after birth, but in some people a small opening remains, and it allows the bubbles to cross over from the right side of the heart to the left side of the heart, and in this way spread throughout the whole body. It turns out to be quite common, as 1 in 3 adults have it, and it is a cause of 50 to 80% of all divers with unexplained decompression illness. So here we have a diver who had just completed 2 dives. The first one to a depth of 21.3 meters that lasted 36 minutes. This was followed 1 hour and 32 minutes later by a second dive to a depth of 24.1 meters with a duration of 44 minutes. He felt uncomfortable on both dives with quite a few buoyancy problems on the first dive and feeling very cold on the second dive. Almost immediately after surfacing from the last dive, he developed symptoms: pain in both shoulders, severe headache, flashes in both eyes, itching to the chest, abdomen, and hips. There were also scattered deep red skin discoloration, localized mainly to the abdominal area, but also it has spread to the ribs, upper arms, and hips. His dive buddies immediately contacted the staff of the dive site. He was put on 100% oxygen. And subsequently, he was transferred with an ambulance, and we started treatment. So on examination here at the chamber, he also had severe problems with balance. His concentration was impaired. The headache that he had slightly subsided, but he was still complaining of visual disturbances and nausea. He vomited once. The discoloration that I showed, which by the way is a very typical case of skin decompression illness, the causes might be different, but this is a very typical, the picture that I showed just now. It's a very typical presentation of skin discoloration. It was still present in this case, although it wasn't so intense. It was localized to the chest, abdominal area, both hips, and upper arms. So what is wrong here with this picture? He had important medical history of migraines with aura. So this is very typical situation for divers who have PFO, that they have history of migraines with aura. So you still need to have a load of nitrogen to cross over from the right side of the heart to the left side and spread out throughout the body though. So all the other risk factors for decompression illness are still valid. Buoyancy problems, rapid ascents, omitted safety stops, they're all contributing, but the PFO just makes this a lot more likely to become a problem. This next case is the experienced instructor. So we're dealing with an experienced instructor with close to 1,000 dives in his logbook. 2 days prior to presenting with the problems of decompression illness, he was diving from a boat in the open sea. The first dive was to a depth of 41.6 meters for 64 minutes. The surface interval was 1 hour and 45 minutes. The subsequent dive was to 23 meters for 43 minutes. At the end of the second dive, there was an incident. His dive buddy had problems with his rebreather and had to bail out and go for the surface. So the instructor followed to provide assistance and ended up having a fast ascent to the surface himself. His dive computer did not sound an ascent alarm, but flagged that he had approached the maximum safe rate of ascent. Both him and his dive buddy were feeling all right after the dive, so they drove home in the evening. So later in that same evening and during the night, he had a headache, but he just took simple analgesia, and that proved to be sufficient enough. So he didn't have any further problems until he woke up in the middle of the night at 5 o'clock in the morning because of significant pain in both shoulders and upper and lower arms, which he put down to lifting heavy gear. However, the symptoms continued to increase, which made him think that it wasn't just a simple strain. So he called our number for advice. On examination, he also had tingling sensation in both arms. He was in considerable pain, and his concentration levels were not normal. He had trouble looking at an answering email, so he realized that there's a problem when he attempted to go to work in the morning. So what is wrong here with this picture? The diving profile is usually the most important factor for the development of decompression illness. So due to the problem that his dive buddy had, the instructor ended up himself with a rapid ascent to the surface, which is clearly responsible for the development of symptoms of decompression illness. It is very interesting that his dive buddy had absolutely no symptoms whatsoever, although he had exactly the same dive profile, considering, especially with the provocative factor of a rapid ascent to the surface. This just confirms that there are a lot of unknowns and individual factors that come into play and make some people more predisposed to decompression illness than others, and make them more vulnerable to the appearance of symptoms. Another important point I want to make is that the dive computer did not register a very fast ascent, only close to the accepted limits. This is a case of a situation which I hear very often when divers tell me, but my computer told me, meaning that they trust fully their computer. And computers shouldn't be trusted completely. They are a device which gives us a theoretical margin of safety, but they're not fully bulletproof. And I end up treating not computers, but the divers that use them. So we should always trust our instinct and observe the safe diving practices. So another case, the absolute beginner. This is just the opposite end of the spectrum. A diver on an open water diver course. So these are his first dives in open water. The first dive that he did on the first day was to 10 meters for 22 minutes. This was followed an hour and 30 minutes later by a second dive to a depth of 9.8 meters for 12 minutes. As is typical for novice divers, they're struggling with the gear, with their buoyancy especially, and this case was not an exception. His mask was flooding constantly, and he struggled with his buoyancy, and ended up having 6 fast ascents in descents to the surface from about 6 meters. He felt tired and rough after the last dive finished, and did not sleep very well the same night. On the morning of the next day, he had developed new symptoms. He had pronounced headache, quite severe actually, 7 out of 10, and dizziness. This prompted him to call for advice. And when I saw him for examination, the headache was getting even worse than initially. After we spoke, his symptoms were progressively getting worse. He had developed nausea as well. There was pain in both arms and shoulders, as well as the knees, and as well as tingling in both hands. He struggled with concentration. His reflexes were generally hyperactive, more pronounced, and he had trouble with balance, quite severe, by the way. So obviously, this is another case where the diving profile is the most important cause for the development of symptoms of decompression illness. The symptoms appeared very soon after diving. There were multiple ascents and descents in quick succession due to the buoyancy problems and the mask flooding. There is no doubt that these rapid ascents contributed to the release of gas when you go up, and also the absorption of the gas when you go down. And because it happened in quick succession, a lot of that gas came out as bubbles that caused the problems. The next case is a very typical situation for a diver, a denial that there is a problem. So this is a very well experienced diver who was diving over a weekend. Very typical scenario for most of us. He did 2 dives on the first day, on the Saturday, 2 dives on the Sunday. The first dive on Saturday was to a depth of 29.9 meters and lasted 32 minutes. The second dive was 3 hours later with 20.4 meters for 30 minutes. There were no problems on that day after the dive finished. Both dives were on air. On the second day, the first day of diving, the first dive was to 39.9 meters for 33 minutes. Second dive 2 hours later, 33.8 meters for 39 minutes. So all done according to the available guidance, with plenty of sufficient surface interval between the dives. On the second day of diving, the dives were done with nitrox 27% as well. So everything should have been absolutely fine. However, he was feeling already tired and achy in the evening of the Sunday. On Monday morning, he started to feel dizzy and started to notice that he has a headache, and his concentration is off at work when he struggled to communicate, have a conversation, write emails, reports. He thought that everything is due to low blood sugar and dehydration. We divers easily find ways to rationalize all the symptoms that we might have after diving. So he was also feeling, by this time, around lunchtime, intermittent joint pain in both shoulders, knees, and the left elbow. He was hoping that the symptoms will disappear, and waited for 3 days for that to happen before admitting that this problem is quite serious and calling the dive emergency number. So further to the symptom that I've already described, his balance tests were all positive. So once again, what is wrong here? The diving profile are usually the reason for the symptoms to appear. All dives were deep and long, and over a relatively short period of time, over 2 days. And this way, the accumulated gas, combined with other contributing factors like cold water environment, dehydration, and physical exertion, going in and out of the water carrying heavy equipment, led to the development of symptoms of decompression illness. The unrecognized case of decompression illness is the next one. This happened on a dive in Turkey, another favorite destination. especially now that we are back traveling around the world. So this diver did 9 dives over 4 days. The dives were varied in depth from 10 meters to 30 meters in range, and the bottom times were from 20 minutes to a little over 30 minutes, with one dive over an hour. She did not report anything unusual during those dives. However, a few hours after he finished diving on the last day, he became aware of a multitude of symptoms: headache, dizziness, tingling below the knees, joint pain, lower back and chest pain at the level of the lower ribs. He did not dive any further and went to seek medical attention and was admitted in hospital and investigated for kidney problems. A CT scan and blood work came back normal, which is unsurprising considering that there wasn't a kidney problem at all. Even though the symptoms had started after 4 days of diving, decompression was not considered at any point as a possibility. The symptoms worsened on the flight back home. So by the time he arrived back to the UK, there were quite a few other symptoms as well. So headache, bilateral knee and joint problems, pain in the chest, tingling in the right cheek, face, back of the head. He was also feeling absolutely exhausted, and his concentration wasn't right. His balance problems he had also severe balance problems as well. So again, the question that we have to ask is, what is wrong with this picture? So we have multiple dives, deep dives over consecutive days. And although there were no reported incidents while diving, this was sufficient enough to accumulate a lot of nitrogen. Seemingly, the dives were all according to plan, but it's very hard to say because he reported that at some point there was a surge. So whether his safety stops were completed according to the established protocols, it's quite debatable. On this particular case, it's very important to understand that here the decompression illness was mistaken for a different condition. And this is especially a problem when clinicians deal with symptoms that clinicians who have little to no knowledge of diving related problems at the dive site. This next case is a case of a diver with a very high body mass index. It's a former rugby player whose sports career is well behind him. So this started as a normal day of diving, 2 dives. The first day of diving, 1 dive to a depth of 28.8 meters that lasted 45 minutes. And that was followed 1 hour and 7 minutes later by another dive to a depth of 21.4 meters for 51 minutes. These dives were uneventful, and the diver did not report any problematic situations underwater or a missed safety stop. Within 15 minutes, however, of finishing the last dive, he started to feel dizzy to the point of not being able to stand on his feet. He had also nausea and became sick multiple times before coming to the chamber. On examination, he still had the same problems with balance. His balance tests were all positive. There was generalized weakness, and he had positive nystagmus when the eyes are moving in a direction uncontrollably. He got sick several times during the examination as well. Now, what was typical for him was that at a height of 182, his weight was 137 kilograms. So he had a very high body mass of 41.4, which is not unusual on most dive sites, inland dive sites in the country, and even abroad. So what is wrong here? So both dives were deep and long. So a lot of inert gas were accumulated in this way. So despite his previous athletic career, this was well in the past. In the present day, reality was that he was unfit and with a very high body mass. This is a significant risk factor for decompression illness. As once the fat tissue gets saturated with nitrogen, it's very difficult for that gas to be off gas safely as a gas. So a combination of deep and long dives, high body mass, physical exertion in cold water environment led to the development of symptoms of decompression illness. This was the second dive the diver had case of decompression illness. To a large extent, he had the same symptoms like the first time, the ones that he presented with the very first time, but the intensity was slightly different. So whenever there's an issue in an area involved with decompression illness, that area becomes slightly more vulnerable to be involved with a subsequent case of decompression illness. So in my experience, divers who have repeated cases of decompression illness can experience some symptoms that involve the initial area as well. So quite a few important points I want to make now. These are the questions that we need to ask ourselves when there are symptoms after diving which are suspicious for decompression illness. Exactly when after the dive the first symptoms appear. Was this the first dive of the day? Has the diver done any multiple days of diving with multiple dives each day? What was the profile of the dive after which the symptoms started? Were there any obvious violations or incidents? And are there any symptoms? Do they stay the same? Are they getting better or worse? Time to the onset of symptoms is also a crucial factor. The first 6 to 8 hours following the last dive before the symptoms appear are crucial for the diagnosis. Symptoms manifesting in the first 24 hours after a dive should be scrutinized extremely diligently for it might be decompression illness. For example, if you fall on your knee, you know why it hurts. But if there is pain or any symptoms that there's no reasonable explanation, most likely the diagnosis of decompression illness becomes the one that is actually the working one. Symptoms following a scuba and repeated dive should be considered decompression illness until proven otherwise. So how to react when you consider that or you suspect that somebody has symptoms of decompression illness? The best advice would be to contact the nearest hyperbaric chamber for advice. Usually the service that we provide is 24 hours a day, 365 days a year. So what is the first aid that we can do? Obviously, make sure that the diver gets 100% oxygen. Ensure that the diver is well hydrated. You should assume that they're dehydrated and they should receive plenty of liquid. If possible, they should drink it as much liquid as they can. You should instill a temperature control. And of course, the first and most important is to be always aware when you dive, where is the nearest dive chamber and the hours that it operates, and make sure that you have the phone number that you can call for advice. Okay, now I would like to slightly change the subject and introduce to you a new successful application of the use of hyperbaric oxygen therapy for treatment of long COVID. This might be of interest because at the moment, the cases of COVID infections are still on the rise, despite the fact that the media probably is not talking as much as they used to before. So this is the situation from a few days ago, showing the people, it's from the official UK government website. It shows the number of people who tested positive for COVID, the deaths within 28 days of positive test, and the admissions of patients in hospital. So we can see that the numbers are still high. The Office of National Statistics also considers that the latest estimate of number of patients suffering from long COVID is close to 1.5 million, which is quite a significant number of patients when you think about, because these are people who struggle severely with symptoms long after they have supposedly said goodbye to the infection of COVID. So what is long COVID? This is the definition given by the World Health Organization. The symptoms are supposedly gradually subsiding after any infection. until they disappear completely. The problem with the significant number of COVID patients, however, is that at some point, the symptoms continue to persist, in some cases, long after they have passed the period of an acute infection. That can be many months, in some cases now, even up to 2 years, because we recently had an anniversary of the first COVID lockdown in the country 2 years ago. Some of these patients are really struggling with a severe condition with debilitating symptoms, so much so that they cannot perform their normal daily activities, let alone do their jobs. So we talk about long COVID, usually if the infection or the symptoms persist for more than 3 months after the diagnosis of COVID. The symptoms are of an extremely wide range, covering the full spectrum of medical specialties. As you can see on the screen, these symptoms have been identified to be more than 200 symptoms. And as you can see, they're not, that this doesn't sound like a respiratory disease, more like vasculitis. Initially, we thought that COVID is a purely respiratory disease, but this just proves that this is not the case. And this is a topic for a whole different conversation about what is behind this disease, but it's a subject of a different conversation anyway. So what is the strategy that the government is following in dealing with long COVID? Well, there have been established NHS long COVID clinics where all kinds of tests are conducted, but they cannot detect anything wrong. For example, MRI imaging scans do not show any abnormalities either. So the patients end up being treated only symptomatically. That is, the symptoms are addressed, but since the cause of the problem is not identified and not clear, the treatment has little to no effect at best. So the most common symptoms of long COVID are on the screen: fatigue, shortness of breath, cognitive dysfunction, memory issues. These are the most common ones. So the treatment with hyperbaric oxygen turned out to be a great success story. On this screen, I present some of the tests that were done by some of the patients during the treatment. You can see that 90% of all patients recovered within 10 to 15 treatment sessions with hyperbaric oxygen therapy in the chamber. The rest of the patients may not have reached 100% recovery, but they also show significant improvement. I'm presenting here data from my very first 20 patients. The preliminary results show that in those 90% of patients that improved, the improvement is between 70 to 100% in each individual case. The leading symptoms of long COVID are thought to be fatigue, and you can see from the tests on the screen that the disease reminds very much that of decompression illness as far as severity of the neurological symptoms and carbon monoxide poisoning. So it made sense to try to use hyperbaric oxygen therapy. I just want to make a little more in-depth discussion about, if you remember initially the cases of COVID 2 years ago, the patients had low level of saturation. That's why there was a dire need of ventilators to treat patients who were suffering with COVID, and a lot of them needed to be intubated. So a lot of patients who did not end up admitted to hospital and needed to be ventilated ended up staying at home. And the advice at the time was, you only call the NHS numbers and seek further help if your saturation drops severely. So there were reports of patients sitting in bed playing with their phones with very low saturation levels, below 60%, which mean, according to the accepted guidelines, means that these patients should have been intubated. So it made sense that if there is a lack of oxygen in tissues, there is a demand of that oxygen, which can be reversed with the use of a hyperbaric oxygen treatment. This is another typical graph that measures fatigue. You can see here the more prominent symptoms. Obviously, the lower with the compressions, the number of compressions after 10 sessions, you can see that the numbers go down. So the symptoms of fatigue disappear, and they diminish in intensity with time and the number of treatment sessions. So why does hyperbaric oxygen work in this state? So the rationale behind using hyperbaric oxygen therapy is that during the acute stages of COVID infection, there's a profound hypoxemia and hypoxia secondary to that hypoxemia, which is lack of oxygen in the blood, followed by lack of oxygen in the tissues. And especially the cells that are, the problems are on a cellular level. So a lot of the imaging doesn't show any problems. There isn't any structure that can be shown to be responsible for the problems because these problems are on a cellular level, particularly the mitochondria of the cells, which stop working. In a way, the nervous tissue responds to these low levels of oxygen more dramatically than the rest of the tissues in the body because it is the most sensitive to the lack of oxygen. So hence, a lot of the patients experience brain fog in cognitive functioning, this cognitive dysfunction. As hyperbaric oxygen therapy has a major role in the treatment of hypoxic states. And in this particular case, it reactivates the dormant cells back into action with reversal of the sustained oxygen death. Of course, there are other mechanisms that help to use hyperbaric oxygen to treat long COVID, in particular, reduction of inflammation, neuroinflammation. So hyperbaric oxygen therapy also stimulates the stem cells, and this in itself has additional anti-inflammatory effects. So in a way, there's a lot of inflammation and neuroinflammation that hyperbaric oxygen therapy addresses. Unlike other treatment modalities that are used, they do not address the pathophysiology, the mechanisms that cause the problems. They're just mostly addressing the symptoms that develop rather than the root cause for the problem. So the table that is used for treatment is a table that takes the patients to 14 meters, 2.4 atmospheres for an hour and 45 minutes. This is Royal Navy treatment table 66. It is a treatment table used for elective patients and is used regularly for approved indications for treatment with hyperbaric oxygen therapy. So all the conditions, even divers that need to be retreated with their symptoms, are treated with this type of table. And the reason to use this table is that we had thousands of compressions. This table has almost no side effects whatsoever and has a proven track record of safety. I just want to emphasize that it turns out that it matters the depth and the duration of the treatment. So once again, 14 meters for an hour and 45 minutes. And this is making all the difference. Some patients have tried other chambers, the multiple sclerosis centers, but they do not use the same treatment table. They use a shallower table, and the duration of the treatment is much less. I can compare that to using medication for blood pressure that is insufficient dose of medication. For example, if you have a blood pressure of 180 over 120, and you take a medication in insufficient dose, it might drop to 160 over 100, but it's still not the target. I've had patients who have had 15, 20 sessions even in these centers, and the changes only started to happen when they started to get the treatment that we introduce and use here. 14 meters for an hour and 45 minutes. So some of our success stories. This was a boxer that after only 10 sessions recovered from her symptoms completely. There's many other patients that from a wheelchair to walking in just days. We had a patient that came in a wheelchair, and 15 sessions later, she was already swimming 20 lengths in a pool. So that in itself was very, very significant improvement and just unbelievable. And it's all due to the magic of oxygen. So the first patient that we saw here in the chamber was on the 11th of January 21 last year. He made very quick recovery after only 10 sessions. So 1 year on, he's still functioning to 100%. And in the past 12 months, there have been more than 100 patients going through treatment. So based on this success rate, we're hoping that together with the University Hospital in Coventry and Warwickshire, we will have a clinical trial to explore further the effects of hyperbaric oxygen treatment for long COVID. Obviously, this is the gold standard for any new treatment or medication in order for it to be approved for treatment. So as a result of that, we hope that this will convince the NHS to adopt this treatment as and make it widely accessible. So for the time being, this treatment is available only privately. And with this, I will conclude this short presentation. I'm open to any questions and I will gladly welcome any discussion. Thank you.
Dr. Michael, thank you very much. That was very kind of you to do this particular presentation. Actually, I'll leave the record running because I think there could be some fascinating questions actually coming up. You certainly provoked a number of questions indeed from myself. And I think I might even start off from myself. With reference to diver medical conditions, what's the typical ppO2 of oxygen would you normally treat a patient?
Are we talking about divers who have decompression illness?
Yeah, divers who have got decompression illness. Yeah.
We are using the standard protocol. It's a Royal Navy table 66. So we take them to 18 meters. So that's 0.8 atmospheres. And the duration of the table can vary to 5 hours, 4.5 to 5 to 5 hours, 40 minutes. It all depends on the response of the treatment. The treatment itself is periods of oxygen that is breathed through a mask, followed by air breaks. And the number of those treatments of those periods of oxygen depends on the response of the diver. Obviously, the target is to get to 100% resolution of symptoms. Sometimes, even with the extensions of the treatment table, we still have to do retreats on the following days. But it all depends, and the decisions are taken at the end of the treatment when I examine the diver compared to the beginning symptoms that they presented initially. Yeah.
So for clarity, you take them down to, is it what, 8 meters or 18 meters?
18. 18 meters. 2.8 atmospheres.
Yeah. Okay. So they're on a ppO2 of 2.8. But for clarity, just for my interest, I mean, would you ever get an oxygen toxicity hit at that level? Because I mean, when one is diving, for example, one is recommended not to go above either 1.3, 1.4, 1.5, or even 1.6, for example, on decompression stops.
Yes, that's why there are air breaks. So you're not breathing constantly 100% oxygen at this.
Okay. Yeah.
You have periods of 20 minutes of oxygen followed by air breaks. So that helps to alleviate any central nervous system toxicity, especially seizures and the like. Yeah. So in my 10 years of dealing exclusively with divers, I've never seen a single one complain.
Okay. Yeah. Okay, no, thank you. There is if you open up your chat window there, Dr. Michael, there is a few questions, and they'll be somewhere near the bottom, I guess. And I'm just going to go to one, and I'll read one out. So, so this is from Aaron. Is 10 sessions of RN66 table the standard number of sessions being offered for long COVID at the present?
I will say that this is the minimum amount of sessions. Now, obviously, there's a correlation between the duration that patients have had the symptoms and how they respond. If you've had it for 2 years, any chronic condition obviously requires more work. I would say that minimum of 10, but it becomes pretty obvious whether the patient responds well to the treatment. I often hear patients say, I see the light at the end of the tunnel, but I'm not out of the tunnel yet. So we continue based on their response. 15 sessions is more likely the golden medium, where most people have significant improvement. But some people need more work. And again, depending on the symptoms. If you come in a wheelchair, I mean, I wish I was a magician or, to make them walk, but obviously it takes a bit more work.
Yeah. And for my clarity, what is the period of time between those sessions? Is it a weekly session, for example, or a
These are
daily?
administered daily, Monday to Friday, so 5 times a week.
Yep.
This natural break over the weekend is necessary because we try to alleviate any potential toxicity of the oxygen. I mean, if you do multiple sessions, daily sessions, some people might feel some of the potential side effects. So this helps to alleviate that.
Okay, thank you. There's a question from Michael VW there, which basically says, are oxygen kit available on commercial airline flights for treatment of passengers suffering potentially from DCI?
Look, the problem with commercial airlines is that they maintain pressure within the cabin that is less than the pressure on the surface. So if you have had gas that was absorbed due to diving, even if you have observed the guidance is about 24 hours, but my advice will be to have a longer period of time. I've had seen those odd ones that observed everything and they still had decompression illness. So make sure it's a longer period of time. Whether the oxygen on board the plane will be useful, of course it will be. Any oxygen is better than none. But obviously, if you suspect that this is due to decompression illness, if there is diving involved before the symptoms appear, I will always think of decompression illness first. You know that saying, if you hear hooves, think of horses, not zebras. So yes, the oxygen can be used on board the plane if they allow you to, of course. But the definite solution is hyperbaric chamber. So once you land Heathrow, whatever it is, please call the nearest chamber and you should start treatment as soon as you can.
Okay, no, perfect. Vivian Shaw has got a hand up. Vivian, would you like to ask a question there?
Yeah, I've actually got 3 questions.
Oh, okay. Please, by all means, more questions the merrier.
Okay, so the first one's fairly straightforward. Does it resolve spontaneously ever?
Decompression illness?
Yeah.
Look, the problem is that, let's say you have been in Southeast Asia and you've had a case of decompression illness, potentially, but you ignore it, or rather it is not bothering you too much. And when I say that, I have seen people that there was a musician who couldn't play his instrument, a string instrument. So to him, that meant that his dexterity wasn't working properly. Yeah. So he was very worried. And I've had another diver say that I can't lift my beer. So you see the spectrum of cases and what is a problem varies significantly between different people. Whether it will resolve spontaneously, I don't think so, because these people usually are hardcore divers that will keep going diving. And then you are adding more insult to injury, because every time you go diving, you inevitably absorb gas. Then if there is an existing injury, the newly absorbed gas will aggravate it, or you might end up, after untreated case of decompression illness, after seemingly something that's very dive that is absolutely, the profile is absolutely fine, that there isn't any provocative episode, no rapid ascents, nothing, you end up with severe case of decompression illness. And when you look back towards the diving profiles in the computer, you realize that there probably was a case of decompression illness in the past. People learn to live with some of the symptoms and tolerate them, but I have not seen a case that has spontaneously completely resolved. Maybe the symptoms are not significant enough to bother you, but there are always some symptoms if you dig deep enough. And this
Okay.
is a fine point to just say that some people have more than one case of decompression illness. And I have observed that, let's say you have the shoulder involved and the elbow the very first time you had decompression illness. The next time you might have most predominant symptoms in your legs, both knees, for example, lower back. But to a certain extent, the area that was involved the very first time is involved again. So to me, that means that every time there's a damage caused by the bubbles that are absorbed, the redundancy, the ability of the body to bounce back and go back to normal is significantly reduced. So if you suspect that you have symptoms that started after diving, it's worth please giving a call to see whether after examination this points more in the direction of decompression illness or something else. Of course, if you fall on your knee and it hurts, you know why, then that's obviously the case. But if you hurt for no reason, then it's probably something to do with the diving.
Thank you. So my
Question?
second question was about partial pressure of oxygen or oxygen saturation. Is it diagnostic? Could you do a oxygen saturation test? Because they're really simple.
Yes, every diver, especially now in these COVID times, I measure the saturation level, but it is not giving me enough information from a perspective of decompression illness, from decompression illness perspective. I think decompression illness is a clinical diagnosis based on the symptoms and their temporal relationship to the last dive or the dive that was provocative. So from that point of view, I wish there was a test that I can ask a diver to pee in a cup and then it becomes pink, and then aha, this is decompression illness. But no, it's a clinical based diagnosis. So saturation levels are one piece of the puzzle, but it's not sufficient enough to point in the direction of symptoms. Or rather, it is not helping me to make a decision whether this diver needs to be treated or not.
Okay. I was thinking more about if you were abroad and you've been diving a lot, if you looked at your oxygen saturation before you got on the plane, if that might be useful.
No, I would always consider the symptoms first,
Okay.
and that's a priority. So, okay, you can send an email. You can even call the number. I mean, it's on the screen right now. But these are the symptoms are leading for that.
Okay, thank you. And the third one was just a curiosity. I'm an anatomist, and my ears pricked up when you said that there was a link between patient foramen ovale and migraines, and I just wondered if are there papers about this? Is it a known correlation, or is it your observation?
Yeah, no, it's not only my observation. It is an accepted fact that people who have migraine headaches with aura, there's a stronger correlation between an existing PFO and migraine headaches, especially the ones with aura. I mean, that doesn't necessarily mean that everyone who has migraine has a PFO, but there's a correlation between the two, and I have seen it in divers. This particular diver that I brought up, he was a typical case. He was examined after that. The examination is an ultrasound examination with a contrast, which is agitated bubbles, funnily enough.
Yeah.
And it showed quite a large PFO.
Cool.
So this was a very typical case of correlation between the two.
Thank you. That's really interesting.
Great. Could I ask a question on behalf of David A? He says, has smoking been a factor seen in some of the DCA cases that you may have treated, Dr. Michael?
I wouldn't say that smoking as such has been a case, but smoking doesn't go alone on its own. Usually it's related to high body mass index, lack of physical fitness, and there's also alcohol, so dehydration. So there are a lot of other factors that come into play. But again, it's the diving profile is the number one cause for the development of symptoms of decompression illness. So this is the thing that I always look into first, other than the symptoms. What were the dives before the symptoms appeared? Was there anything provocative? Was there a rapid ascent? Was there a seesaw profile? Were there too many dives over a short period of time? what was the surface interval between them. These are the leading symptoms. Smoking as just a limiting factor by itself is a contributing factor, but it's not the only one, and it's not the leading one.
Great, thank you. And there's a question from Leo, which says, what level of care can you provide to a patient in a chamber? I.e., could you take a patient on vasopressors, stroke intubators, etc.? What are the medical equipment considerations in a hyperbaric chamber?
Okay, if the patient is so severely impaired that it needs to be intubated, he's not, in my opinion, a good candidate to go in the chamber if the condition is so severe. In my experience, the patient needs to be stable enough in order to be able to get treated. So there should be a note of priorities first. These cases that require intubation, usually it can happen in people who are using rebreathers. They have done very deep and very long dives, 300 meters, for example, for 8 hours. Some catastrophic decompression has happened from significant depth, a rapid ascent to the surface because of malfunctioning equipment. So these are the cases which probably will happen for divers who are having in open sea. I see mostly patients who are diving inland in the local quarries and also who have been traveling abroad. So they're probably more of the walking and talking kind of patient, although they have severe symptoms that require treatment. But these patients that require such level of care, they probably need to be stabilized first before we think about even going into the chamber. I hope that answers your question.
Great, thank you. Seb Chandler has got his hand up. I'm assuming it's he. Could you ask your question, please?
It's actually Chandler, but thank you,
Chandler,
Michael, for
sorry.
the presentation. I wanted to follow up. I think it was Vivian Shaw's question about the association between PFO and migraine with aura, and I wondered, is there for someone who is a regular diver, is there a correlation between the size of a PFO and the frequency of attacks? And would that lead to would you say that if a diver was to suffer from X number of attacks a week, that there would be a reason for them to get investigated for a PFO?
Okay, you have to understand that the existence of a PFO by itself does not necessarily mean automatically decompression illness.
Mm-hmm.
You still need to have the load of inert gas of nitrogen that has to cross over, and the PFO is like a gateway from the right side of the heart where the venous blood comes in with all the bubbles that normally should go to the lungs and be exhaled as a gas when they're filtered. And it's a gateway that allows these bubbles to cross over to the left side, the arterial side of the heart, where it starts to spread out. These bubbles start to spread out throughout the body. Couple of things. The effect is very dramatic, so the symptoms appear very quickly. In this case that I described, it's a textbook example of a PFO and the way it influences diving, because the diver had neurological symptoms, central nervous system neurological symptoms, within 15 minutes of surfacing. So obviously the PFO was quite large and open, bubbles crossed over, and they spread out to the brain, and that's why he was affected so quickly. He had visual problems, he had flashing lights as well as a presentation of decompression illness. So whether the number of migraine attacks in a given week is a correlation to how severe the decompression illness will be, I do not think so, because you might have a case of PFO and it only can appear 2 years later. I had an instructor from down south. She was working full time as an instructor on the channel in the Channel Islands. So she had 4,000 dives, and after 4,000 dives, she changed her dry suit. So you can imagine that the new dry suit was compressing her abdominal cavity in a different way. Some of the blood that's normally returning to the heart, the venous blood, the new dry suit probably compressed in a different way, and it crossed over. So after 4,000 dives only, she had a case of decompression illness. So you still have to have a load of inert gas, so you still have to dive. You still have to have provocative episodes, whether it's too many dives over a short period of time or too deep and long. This has to be there. And also, with the existing PFO, the behavior after the dive itself is also very important. And by that I mean, if you have to lift heavy gear, which inevitably diving gear is very heavy, when you're exerting, let's say you're lifting something heavy, the pressure in the abdominal cavity naturally increases, and this compresses the larger veins that deliver blood to the heart. So some of it may cross over. So you can see it's your behavior after diving, physical exertion as well. There was a case of this diver that was that I presented, the very first one actually. He had to swim on the surface 150 meters before getting to the dive site, and then 150 minutes after the dive. You can imagine that this is all the gas that is inevitably absorbed in the body will start to circulate as bubbles and cause a problem. So if you have a PFO, obviously that will be more dramatic than if you don't. But even if you don't have a PFO, physical exertion after diving should be avoided. I hope it answers.
I guess what I'm driving at is, to what degree should a diver suffering from migraine with aura be concerned that they might have a PFO that would cause them symptoms when they, obey all the rules? Is there a case for people who are routine divers with migraine with aura to have an investigation to see if they have a significant PFO?
Well, I wish I could say that every diver can get a test or should get a test for PFO. It's obviously not practical and pragmatic.
Okay.
You have to modify your diving a little bit. If you, let's say, you want to pursue technical diving or something that's more extreme, like you want to work as a diving instructor, with this history, I will recommend that you definitely have a test. So something else that needs to be mentioned is that not every sonographer who does cardiac echo ultrasound examination of the heart performs this test frequently enough to be, it's a very subjective test. So you have to have somebody that is very experienced and does this test frequently in order to be relying on the result of the test. This is a very subjective test, and it's like an art form, really, because the way you hold the transducer, the way you observe, the way you ask the diver to perform Valsalva, so you can check whether some bubbles can cross over. It's really an art, really. So again, being pragmatic, first of all, depends on the type of diving that the diver will do. If it's only holiday diving abroad, Red Sea, 10, 12 meters, 15 meters, 2 dives a day, every 2-3 days, I wouldn't worry until they develop decompression illness. And even then, if they develop a second case of decompression illness, I will absolutely advise them to get a test done.
Thank you.
Again, the diving profile, please, if you remember one thing, if you take away one thing from today, it is that the diving profile is the #1 cause for the development of decompression illness. And that is not only the single dive, but the multiple dives, the succession of dives, multiple days, the liverboard, all these things are more important than whether you have a PFO or not. So advise again, the physical activity after diving as well. Avoid any strenuous activity. Lifting heavy gear, better give somebody 10 pounds to do the heavy lifting for you.
Thank you very much. Thank you.
Great, thank you. Nick Elrington has asked, normal diver treatments I thought were on table 62.
That's correct.
If treating on table 66, are extensions permitted,
No.
like on 62?
No. The table that we treat divers initially is a deep table. It's 62. table 62. That's the 18-meter table. It is equivalent, almost identical to US Navy table 6. So this is the initial table that we treat divers. I've seen around the world people have been treated with different tables, but in my opinion, it was insufficient medication. So again, if you treat blood pressure, you need to treat it aggressively enough to achieve the desired results, not just scratch the surface. So yes, Royal Navy table 62 is the one that we use for divers. 66 is used for retreats if necessary.
Okay, great. I hope that's answered Nick's question. A question from Ray Kramer. Two divers, the same profile. If one is heavier breather or worked at depth, so has absorbed more inert gases, are they more susceptible to DCI?
If they're a heavy breather, that you have to ask yourself whether there are not other factors. What is their physical fitness? Are they just a heavy breather because they're extremely fit and, when they take a deep breath, their lungs are as big, they take a lot of air? Or it's just simply that they're struggling because their BMI is very high, they are unfit, they have other comorbidities, let's say high blood pressure, some diabetes, it's not an exact science. And also their behavior underwater. What is their profile? Again, I want to emphasize that. Are they having a knife safe profile? Do they have enough surface interval between the two dives? This is probably more a case of observing, the correct diving procedure rather than just whether they finish their tank. I mean, my wife breathes better than me. I mean, obviously she will last longer if it comes down to that, but I don't think that this is the main thing. You don't have to spend 70 minutes underwater. You can spend comfortably 40 and then do another dive. But it all comes down to how you moderate the risk factors, how you mitigate the risk factors. And again, number one cause for decompression risk is the diving profile. Does it answer your question? I hope it does.
Mm-hmm. Yep, I think so. I'm going to ask a question, if I may. There was a study done, I think, a few years ago with reference to underwater heated vests, whereby they say using a vest at depth, for example, and heating up your blood increases your circulation and hence may increase the onboarding of nitrogen, and therefore one's recommended, for example, to utilize a heated breath only on a decompression stop when you're trying to remove nitrogen. Have you ever seen any cases of this whereby it could be put down to a heated vest, or is this just hearsay and possibly a myth?
I have not observed any of the divers that I've seen with a heated vest. Now, if we talk in theoretical terms, you should be very cold at the beginning of a dive and very warm at the end, because then you can off-gas and not hold on to the gas that you absorb. But unfortunately, especially in these waters in this country here, it's not possible. It's the other way around. You start warm and then you're very cold at the end of it. So you hold on to this gas. I personally think that if you need a heated vest, probably the environment is not very recreational. And I will not advise diving in that environment because the risks become much higher. I do not think that, this is my personal opinion, I do not think that this is a solution to the problem. It's probably better insulation that you need, or choosing a better dive site, probably.
Yep. Okay. No, thank you. There's just a comment here from Steve Fritzl, basically saying to actually one of the earlier people asking a question of Michael VW, which basically said the oxygen is usually stored in the overhead bins marked for passenger not for passenger storage, or labeled specifically for oxygen, so you know where to go and hunt out your oxygen in that case. A question from Peter. he says, if a diver has a high BMI and has had DCI in the past, if they reduce the BMI, would this help reduce the possibility of getting DCI again?
Undoubtedly, that will be one of the factors, because in the process of reducing their BMI, probably their physical fitness will improve significantly. But again, it depends on what profile of the dive. I mean, what are the diving profiles that they will be doing? So if you have rapid ascent to the surface because of a free-flowing regulator from 21 meters, you will end up with having another case of decompression. So it's not exactly the reduced BMI is an absolute. It's a factor that prevents the development of decompression illness. But again, and I just want again, I mean, I'm probably emphasizing it enough, but I don't know is it strong enough. The diving profile is the number one cause for problems. If you have a catastrophic ascent, rapid ascent from 23 meters, you can expect that you will end up with some problems, because it's simply the laws of physics. I've not seen a person who is stronger than them and can fight them. So really, you absorb gas, that has to come as a gas that you exhale. That's why the ascent rate to the surface is so important. If you have a rapid ascent, inevitably some of that gas will come out as bubbles and it will cause problems. But yes, I will strongly advise that you reduce your BMI.
Great, thank you. David A has also asked a question. How efficient do you see diving safety stops to be elongated as much as possible? So I guess the question is how long should a safety stop be? So, for example, here has said, instead of 3 minutes at 5 or 6 meters, one should spend 10 to 15 meters or more. At which point, realistically, would these not help reduce the risks of DCI? So I guess what we're saying there is, at what point should we pragmatically finish a safety stop? Is going longer than the recommended 3 minutes a real benefit, or
Yes.
And then how long should that time be?
Okay, how long will you? How long do you need to have a safety stop for?
Yeah.
Well, it depends on the environment. If you're on a coral reef, I will advise you to have as long as you can. And if you have 15 minutes of air, stay at 5 meters. You still have things to see, things to observe. Now, probably it's better to say that controversial subject about deep stops. I think that's not a good practice. I have seen a few divers through the years that were doing a lot of deep stops. Maybe some tissues that have absorbed gas will start off-gassing, but you absorb gas in other tissues. So it's a bit of a knife that cuts both ways. I will not advise deep stops, but I will certainly advise longer safety stops at about 5 meters. If you have enough gas, you can spend all of it, if you're comfortable enough as well. If you can spend 15 minutes, 20 minutes, if it's a coral reef, there's plenty to see. You will not be bored at all. So that might turn out to be quite a pleasant time spent. Of course, if the water is 2 degrees water, you want to get out of it as fast as you can, but then obviously you have enough insulation to last. But yes, my personal opinion is that the longer the safety stop is around 5 meter depth, the better it is. It again, it depends on how much air you have. But if you can make it longer, please do.
Okay, that's great advice. Robert, if I just flip the screen. So Robert Bromley, if I've pronounced his surname correctly, said, with regard to DCI symptoms, with neuro symptoms being prevalent, was this based upon presentation at a chamber? ? That is, the results skewed towards symptoms that are concerning enough to seek help versus mild symptoms?
Okay, there is a variation of what we call mild symptoms, because some of the cases that I presented, the symptoms progressively got worse. So they started with something relatively mild, that simple analgesia, you have a headache at the end, but that headache progressively got worse during the night. So woke the person up at 5 o'clock in the morning. Severe headache, severe pain, severe balance problem, dizziness, nausea. So the neuro symptoms are probably the one that are always present to a certain degree. The intensity varies in the presentation, and again, it depends on the dives that were preceding the appearance of symptoms. This is not a case of whether they present to the chamber with neurological symptoms or they're mild, because these symptoms can progressively get worse despite initially being mild. So it's a question of whether the symptoms that you experience, there isn't any other reasonable explanation. And if not, it very well might be a case of decompression illness. Okay.
Yep, good. From KP, he said, is subclinical DCI a real thing? Question mark.
Yes, I think it is. Again, it's a similar situation with people who have a presentation of decompression illness and then have a repeat presentation. And the area that was affected initially, the very first time, is affected again. So to me, that means that we probably, well, think of it this way. Technical divers, they bend themselves underwater, and because they're so good at unbending themselves underwater, they do not have symptoms. I have very rarely seen proper technical divers needing a chamber, because usually there's some malfunction of equipment or something that went wrong, not according to plan. So they have become masters of how they manage their profiles. Everything is there to manage their load of decompression illness, but they certainly probably have subclinical symptoms which they manage well underwater with the procedures that they observe, with the 100% oxygen at shallow depths, with the 60% in the mid depths as well. So I do think it's a thing before becoming clinical. Obviously there is a load of gas that our bodies can take without presenting with too severe symptoms, and that is a fine balance that needs to be not tipped in one direction, in a negative direction, obviously. So that's why I would say, if you do multiple dives over multiple days, have a break every so often, every 3 days, really. You stop diving in the morning and then you dive in the next day in the afternoon. This is a very healthy way to approach the subject. But to answer your question with one word, yes, I do think that subclinical DCI exists.
Great, thank you. I believe Sam might be after your job, Dr. Michael, by asking the question, what was your route into hyperbaric medicine? Did you start your training as an anaesthetist or a respiratory physician? Question mark.
Funny. I started as a diver first and foremost, so my interest grew. So it was a bit of a Jekyll and Hyde situation. So my Jekyll doesn't hide anymore. I started as a nephrologist, and then this was my hobby, but the hobby took over, and then I'm fully committed to this course. So you don't have to be an anesthetist, because it all makes sense. And I had a lot of experience. I'm a diving instructor. Used to teach a lot of divers, but these days I probably dive behind a desk mostly and dish advice and do medicals, diving medicals. But it started because of a pure love for the sport, for me personally.
Brilliant. Thank you very much. Just looking down the question list again. In fact, somebody was just saying there about what was your feeling regarding to deep stops. I think you've answered that one already. From Michael VW, I have been told that osteoarthritis is a predisposition for DCI. Could this be true?
I wouldn't, personally, I don't think it is a condition. Look at the dive profiles and look at the dives, look at whether there was any rapid ascent, whether there was a seesaw profile. The osteoarthritis is painful joints due to overuse. If you're middle-aged, you've been working in a heavy industry, or you have some predisposition, you probably have some mileage that can cause osteoarthritis. I don't think it is the main factor that causes decompression illness. Some of the symptoms of osteoarthritis, though, can be mixed or matched with symptoms of decompression illness, especially joint pain, peri-articular pain that is similar to that. But and again, overuse injury. I mean, you're lifting heavy equipment, cold water. Your osteoarthritis can become aggravated because of the dives that you've done, the environment that you were diving in. Yeah, I think this is more a case of, again, the diving profile rather than just the osteoarthritis, rather than the medical condition as such.
Mm-hmm. Good, thank you. A question from Adam Gillett. Is basically said, how important is the 1 minute ascent? This is from the 6 meter stop to the surface. He says, I see too often divers doing the 3 minute safety stop, but then rapidly ascend to the surface after in about 10 to 15 seconds.
Yeah, you should ascend very slowly. I mean, in my crazier days, I was probably doing too many things that now I'm horrified when I think about them. But you should ascend slowly. You know that there was a saying that never faster than your bubbles, and I think that's a reasonable speed. You know, the faster ascents, even from 6 meters, can become a problem. If you do multiple dives with the same approach, probably one day you can end up with clinical decompression illness, but certainly subclinical. I would say that you should take it very seriously until you get to the surface, and unless you're saving somebody who is having a catastrophic event underwater, they're running out of air, or it's something going on, you should never go back. You know, whether you have lost your camera or your dive knife, this thing happens. But this is asking for trouble if you go back down, or if the speed with which you ascend, even from 6 meters, after you've done a 30-meter dive for 40 minutes. Of course, I will approach the ascent from 6 meters to the surface very, very cautiously as well.
Great, thank you. There's just a comment from Aaron. Basically, this was at Sam, saying that the DDRC will hire and train a few doctors each year in hyperbaric and diving medicine. You do not need to come from a specific speciality. So that's a track into hyperbaric medicine. But also maybe a question for me, and that's that same subject, is that there is the law changed. I think was it in 2008, whereby you do not need to, I don't, do correct me if I'm wrong, that you do not need to be a doctor to prescribe oxygen, and so therefore, you know, there is a number of chambers around the country, for example, and you know, the number of 84 comes to mind in order for the treatment of multiple sclerosis, for example. Does one have to be a trained doctor in order to, for example, help out like a diving supervisor at such a chamber?
Okay, the multiple sclerosis centers, obviously, they using this loophole in the law, and they operate more like a kelp spa saloon.
Yeah. Okay.
Tanning beds. I don't know. I mean, okay, I don't want to put them down, but obviously they don't use the same pressures for treatment of divers. There are 8 chambers in the country that are approved treatment of divers. I operate one of them, but you have to have a physician that knows what they're doing when you treat divers. The other chambers don't have the capability.
Yeah. But for clarity, would those other chambers just be utilizing less pressure, for example?
That is correct. They have a limitation of pressure, and they use different tables, which again, people have jumped on the long COVID wagon.
Yeah.
I believe we started treating long COVID first in the country, but it makes a lot of sense. But these chambers treat them, but I don't think that it is sufficient enough as a medication. So you're getting a lower dose of a medication. So it depends on the condition. For multiple sclerosis, maybe it is sufficient enough, but for other conditions, certainly not, in my opinion.
Yep. Perfect. Thank you. Let me just, there was just a question from Hector. I guess it was about almost like deep stops, but he basically said, why are slow ascent rates favored, but not deep stops? What is the difference?
Well, it's obviously that the deep stops, you're stationary. The whole idea behind the deep stops is that you will off gas, but that's, to me, that's just piece of the puzzle, because some tissues you will off gas certainly, but other tissues, simply because you're standing in the water stationary, you will on gas, so you will absorb more gas in those other tissues. Well, the slow ascent, you are doing it observing the laws of physics, obviously underwater, and the gas that is coming out of the tissues that was absorbed, Henry's law, it will go back with the blood to the lungs and will be exhaled as a gas.
Mm-hmm.
When you get to the shallows, then it makes a lot more sense to have a longer stop to continue to off-gas the tissues, because the chance of absorbing more gas is much less than at a deep stop. I hope it answers the question.
Yeah. But for clarity on that particular point, I mean, I've even been told, not to hang around, for example, and continue at the rate the tables will allow you to do so, or your computer will allow you to do so. So, if, for example, your computer, is the optimum rate is 10 meters a minute, is crack on at 10 meters a minute, and don't go at 3 meters a minute, for example. So 3 meters a minute in terms of like slowing your ascent rate down. Is that true? And also, maybe just to add on to that question, again, I don't know whether it's a myth or not, is that because of the non-linearity of the expansion of bubbles, for example, is that if you're on a very, very deep dive, then you basically just crack on at the bottom, and then you slow up your ascent rate, and this is technical diving depths, I should add, and slow up your ascent rates as you go past 50 meters and as you head towards the surface.
Well, I have a special relationship with computers.
Yeah.
Because I mentioned already when I was presenting that a lot of divers tell me, my computer told me, and they're surprised that they end up with decompression illness. But the computers use theoretical models. Doesn't matter, even the most expensive ones. They use theoretical models that probably, the Navy tables were created using healthy Navy volunteers, which they pretty much put them down to depth and waited until they get bent, and then that's how the tables were created initially. So you can argue that a computer, their algorithms are not universal for every person. So you should observe the old school rules of not trusting completely the technical devices, but using your common sense.
Yep.
Of course, you have to have a slow ascent simply because you want the gas that you inevitably absorb. I mean, if you look at it this way, even nitrox, even the air can be classified as nitrox, only it's nitrox 21% of oxygen, right? The other mixtures have a higher percentage of oxygen, but it's still nitrox. There's an inert gas in it. So even if you breathe nitrox, you're not immune to getting decompression illness or some of that nitrogen to be absorbed. It gives you a bigger margin, but it's still not eliminating the risk completely if you have nitrox. So in the same way, trusting completely a computer and the diving guidance, it's just probably not a very good idea. You should use your common sense. Your ascent rate should be slow, and you should have an extended safety stop in the shallows. That is my advice.
Okay, no, thank you. Just going down the rest of the questions, there's probably just the last one at the bottom, I think. There's been plenty of praise, I have to say, within the chat window. From Alexis Moreno, who has said, if you have a choice of a dive algorithm on your dive computer, I'm sort of quite conscious of your last answer, not to trust a dive computer. Would you prefer to choose Bullman or VPM or RGBM? Which would you choose?
Well, my choice will be common sense. That is the algorithm I will choose. I wouldn't say that any computer is better than the other. I mean, when I dive, I use two, and a watch as well, and I even have a table in my pocket. I mean, since I've been involved with decompression, I've become so much more cautious that I'm sometimes it takes the fun out of diving. But I would say that common sense should be the algorithm that you follow, and slow ascent, longer safety stops in the shallows, longer surface interval between dives, 2 to 3 dives a day maximum. Don't go mad on a liveaboard, 5 dives a day. I have even had people that on a liveaboard, they knew that they were bent on day 4, but because they have paid for it, they kept diving. Yes, that happens. So don't do that, and the algorithm doesn't really matter that much. Don't go to the limits of whatever algorithm your computer is following. Just stay well within of the limits, unless you're doing special kind of diving, technical diving, or but that's a different category of diving altogether. I actually want to say that my experience with technical diving and rebreathers is that you can do exactly the same profile with another person, and somebody might get decompression illness simply because there are other factors come into play, and they come into play to a much larger degree than only with only recreational diving that's based on air, because physical fitness is paramount. I would say that technical diving is on a par with proper commercial diving. Physical fitness, body mass index, fat content, hydration. I mean, there are individual predispositions to some people have bubbles, others don't. So there are a lot of other factors that come into play. So trusting your computer blindly is not a wise decision.
Yep. No, great. Thank you. And I think that is probably the last question we have for this session. I'm just reading maybe some last comments. See if there's anything there. No, I think we're done. So my last comment is simply going to be Dr. Michael Gonevski, thank you very much for this evening. We very much appreciate your time that you've spent with us right now.
It's a pleasure. It's a pleasure.
And it's been very informative and bags of fun. So I and BSAC would like to thank you very much for this session. And there is lots of praise in the chat window, and there's lots of people clapping across the internet as I speak. So without further ado, I will draw an end to this evening. And yes, so I thank you, and I thank everybody for turning up. I will stop the recording presently.